Thanks, Allie. We are recording today's session, so we thank you for joining us. We will be posting this both on the Indiana Rural Health Association YouTube page and the Upper Midwest Telehealth Resource Center YouTube page. So without further ado, I do want to go ahead and introduce Greg James with Telepharm. Greg and I have been working together, I don't know, for almost 2 years now, it seems like, as their company with the, you're going to learn all about the innovative things that their company is doing and bringing pharmacy services to rural areas all across the Midwest. So Greg, I'll turn it over to you.
Great. Well, thank you, Becky. I appreciate the invitation to join you today. And I think you're right. I think it has been almost 2 years now. It's incredible to think how quick time goes. So I just wanted to pull the presentation. Can you guys see my screen okay?
Yes, it looks great.
Okay, great. So again, I appreciate everybody coming today, and excited to be able to share what we do and a little bit about the history of telepharmacy with you and how it's being used today. Our company is based in Iowa City, Iowa, and a little bit that I don't have in the presentation, but a little bit just to cover here ahead of time. It was really what we do was born out of need here in rural Iowa. Our founder had his family had a number of pharmacies right here around the Iowa City area and smaller rural communities, and they were closing down. This is around in the 2010 timeframe. And so in 2012, he founded Telepharm and opened the first telepharmacy here in Iowa, based off of some of what was learned in North Dakota and other places. And since then, we've done a lot of looking into what other people are doing and how things are going across the U.S. and wanted to be able to provide you guys with a lot of information about what telepharmacy is, how it's being used, and kind of some of what the regulatory environment and some of the activity is going on here on the U.S. So without further ado, I'll kind of hop into things. And we'll, as we kick things off, I wanted to let everybody know what telepharmacy is, in the sense that we use it. So we have a couple of different ways that telepharmacy can define. In our sense, it's for retail pharmacy or outpatient pharmacy. And there's two major components to it. One is the prescription verification side of things, where a pharmacist in a remote location is actually checking and verifying the prescriptions that are being processed at the telepharmacy site. And then there's the counseling and education side of things, when the patient and the pharmacist are connected via live connection, live video, so that they can discuss all the medications and any types of other things that the pharmacist can counsel the patients on. And really quick, I wanted to toss this in here at the beginning so you guys could get a concept of what one of these looks like. This is a telepharmacy in State Center, Iowa, that is owned and operated by New Care Pharmacies. And this particular location, as you can see, has towards the back, you can see the counter and then where the prescriptions and medications and everything would be. But it's a larger building that the city brought up to historical preservation quality that the pharmacy then moved into. So they look just like any other typical pharmacy you would see. Very large. They can be smaller, but they can also be very large. But the only difference that you'll see in this model is that we're connecting that pharmacist remotely rather than having them directly there on site. So let's hop into a little bit of the history of how this came to be. In the U.S., the major impetus that started all of this telepharmacy was North Dakota passing laws to allow for it in 2001, and then they had a few more things. They had a study that took place in 2002, and a couple other people that kind of came on board. And then we always like to toss this in at the end that in 2012, when we came around, a little bit of a new generation has started. But really, the starting point for telepharmacy in the U.S. Was with North Dakota, and specifically with North Dakota State University's study that they did. That study was from 2002 to 2008 and involved 81 pharmacies across the state. And really what they found from that study during this entire time period is that the dispensing errors, the number of errors, was half of what the national average was. So they were able to reduce prescription dispensing errors by 50%, and that's a really big reduction. And so the outcome from this entire study, it was a federally funded study, was that it's safe to do, and it can definitely be something to provide access in rural areas. What they found, though, at the time, was that the technology, really limited how they could roll it out on a larger scale, on a larger commercial level. We put some screenshots here, some pictures here, some of the different technology they're using with these large TV screen sets, very expensive hardware. That would get outdated quickly, and many times, if you wanted to have any kind of operations at scale, it would just cause a lot of problems and issues. So there were a lot of in the earlier days, there were a lot of challenges to this. Even though they proved that it was safe, it couldn't really become something that was widespread and accepted across the U.S. because it was just limited with the technology. So then what we see is that there was a lot of changes in the industry. Specifically, a few of these things that we've called out. Obviously, in 2006, we had these major policies with the prescription drug discount cards and Medicare Part D, which is a huge change in the pharmacy side of things. Then we had the global financial crisis in 07-08. And then 2010, the Affordable Care Act also changed the industry a lot, and it really created this need, a greater need than there already was, for delivering these services in an alternative way, and not how we've always traditionally done it with a pharmacist on site. And what we saw picking up in about 2003, so about the same time the study was starting to take place in North Dakota, was that pharmacies were closing across the U.S. And there's been a continual downward trend over the past decade or so. This particular data is from the Rural Policy Research Institute out of University of Iowa here in Iowa City, and they found a 12.1% decrease from 03 to 2013, with obviously a lot of those happening during that global financial crisis. But it's not something that's just restricted to a specific area. It is something that's widespread across the entire United States, and it's something that affects everybody, and specifically in rural areas. Most of the closures that we're seeing that really impact patients and residents are the ones that are in rural areas. And I like to always point out that from 2003 to 2013, 924 independent rural pharmacies closed. But 490 of those, which just seems like a very large number to me. 490 of those was the only pharmacy in that community, and so 490 communities lost their local access to a pharmacy in the past 10. Well, in these previous years, which the trends are continuing today. It's not something that is letting up. It's something that continues even today. And what we're seeing because of these closures now, the picture here is a little excessive, but it's definitely, we're seeing that the main street in some of these small towns is struggling. Pharmacies have been a staple in small town America for a number of years, and because they aren't able to sustain themselves in these lower population and lower volume areas, you're seeing that they're closing for these financial reasons, which leaves a gap in the healthcare and really starts fragmenting the care that the patients can receive. Maybe there's still a doctor locally, but without a pharmacy, they're still going to have to travel out of town, and things kind of get lost in the mix. There's also, obviously the job loss. Every time a business goes out, or every time a business shuts down, you're going to lose those jobs. And then the major piece that we're starting to see has a larger and larger impact is the medication adherence, and the decrease in that medication adherence. The more difficult it is for patients to get their prescriptions, the less likely they are to take it, and the less likely they are to be adherent to it. So we put together some of the statistics and some of the studies that have been done here in the past 10 years or so. How many Americans are taking prescriptions? How well are they taking it? But the one that I always like to point out is this: 31% of new prescriptions, it's a third of all new prescriptions go unfilled. And I was just looking through some data the other day that said, 9 months later, it's you're lucky if even a third of those patients are continuing to take their medications as they um, as they as they should. So the readmission costs of medication non-adherence and the health outcomes from that medication non-adherence are becoming a really huge factor in what people are starting to look at as a determining factor of people being able to stay healthy. So we're going to fast forward now. We went through a little bit here, the history and how it came to be, and there's definitely a need for this. What happened is in the past few years, we've seen kind of this perfect storm of technologies and advancements coming along, and a lot of companies are taking advantage of this. You know, Amazon obviously has really disrupted the retail market. Uber is, if for those of you who aren't familiar, Uber is incredible for those of us who travel, and really disrupted the transportation industry. And then ZipDrug is skipping the pharmacy altogether, but not necessarily giving us better service. But these types of things are starting to disrupt the industry and look at, can we provide these services in a different way, which is where we come with telepharmacy, and where my company really comes into play is the technology was available through broadband access now that's becoming more and more prevalent in these rural areas and small communities. The cloud services that are available and the decreased costs for hardware have really kind of all come together and allowed these new advancements to take place, and allowed us to start looking in different models. So the way telepharmacy works on a very simplistic level is what we have here on this diagram. You have a pharmacist that's in a central or hub location, and at the managing pharmacy can oversee, let's say, up to 3 telepharmacies. And in these telepharmacies, you'd have a pharmacy technician, a certified pharmacy technician, working on site filling prescriptions, just like a traditional pharmacy would be. But that information is all being sent up to that pharmacist at that managing hub site. And what that means is now, instead of each one of these smaller locations needing to support a full-time pharmacist, they only need to support a third of a pharmacist, or even less, depending on how you create the entire network and model. And what that means then is a town of, let's say, 2,000 people who really had a hard time supporting a full-time pharmacist on site. They now can either, if that pharmacy closed, they can reopen a pharmacy, or if they never had a pharmacy, they have the opportunity to bring one to their community, and they can share that resource then between those sites, and it makes it feasible and sustainable for the long term. And now, obviously, this can get a lot more complicated as well. We're able to now start connecting specialists or any type of pharmacist to different locations. So you can create an expansive network. We can connect them to health centers. We can connect them to pharmacies. We can have HIV specialists. We can have dietary specialists, nutritional specialists, diabetic specialists. All these things we can connect in, and you're sharing those specific specialty resources then across multiple locations. So instead of having to have this specific individual specialty in one specific location, now we're able to give them access in a number of different locations. So those of you who aren't very familiar with pharmacy or pharmacy workflow, we put together just a quick slide here so you can see what the difference is. And essentially, it's the same as a traditional pharmacy workflow. They're gonna enter their information the same way that they do today. The technician is going to get that prescription, get the stock bottle and all the things that they need, the vial, to fill that prescription. And then as they fill the prescription, they in many of these modern systems, they're going to take pictures or images of that prescription as it's being filled. And that's really the biggest difference, is that technician is just going to take images, and then they're going to package that together and send it up to the pharmacist who's in the cloud. But other than that, typically a technician would fill that prescription, and then the pharmacist would verify, which we're doing. We're just doing it with a pharmacist at another location. And then when that patient needs to be counseled by the pharmacist, when they're ready to receive their prescriptions, they're going to be connected to them through a large tablet, and almost like a FaceTime, where they can then speak live to that pharmacist, ask any questions, and that pharmacist can provide all of those clinical services. A few more pictures. I always like to share what these actual locations look like, and they don't look any different than any other traditional pharmacy that you would see. This is Victor Drug in Victor, Iowa. This is the first one that our company opened. It's been in operation for almost 4 years now, and that's actually the governor there in the middle. The governor of Iowa was out there for the grand opening. But inside, you'll see it looks just like a pharmacy that you would be familiar with. It's a little hard to see the over-the-counter medications that are on the right-hand side of this picture that are up against the wall, but it has a small over-the-counter section. Then it has this counter and this private area for the technicians, the certified technicians, to work. And we have a couple extra monitors and some cameras, but that's about the only other difference you'll notice, because over here on the left-hand side, you'll see the full prescription inventory, and then the will call area, all those things. So it's just like a traditional pharmacy. Except that pharmacist isn't there. Here's another example up in Wisconsin. This is in a children's hospital. They wanted to have these services available here locally at the children's hospital. So here's the images inside of this. It's, again, a traditional pharmacy. Yep. Okay, I'll keep going here. So this is again a traditional pharmacy. You'll see it has just looks like any other pharmacy you'd typically see. And in this one, I always like to point out here on the right side, you'll see the tablet. They're sitting with the chair, and that's how the patient will connect to that pharmacist. They have a button they can push, and they'll immediately be connected to that pharmacist. And that pharmacist will have their prescription information and be able to counsel them on all those medications. So quickly diving in now to the regulatory side, we haven't made huge amounts of progress since 2002, but there has been quite a bit of progress. You look at 2008. Based on what North Dakota was doing, we had a few states that had opened up in different ways, had opened up for telepharmacy. But then fast forward to today, we try to keep this as updated and accurate as possible. But a lot more states are passing rules and regulations that allow for this type of service to be provided. And so diving in a little bit more with the actual the actual Upper Midwest Telehealth Resource Center states that we're talking about today. There's 4 states: Illinois, Indiana, Ohio, and Michigan. And so with Illinois, very briefly, it's allowed. Illinois passed their laws in 2010. We use Illinois laws, and a lot of other states do as well, for model language to base their own language off of. It's very well defined and very clear. And I don't know the specific count, but I know there's over 30 telepharmacies that are in operation today all over the states, from rural areas all the way up into Chicago, serving subsets of the population or restricted populations up there. So Illinois is a great state. It allows for a lot of different things, and we're seeing a lot of innovative ways that telepharmacy can be used throughout the state. Switching over to Indiana, where I know Becky's at and the resource center is at. I was just there on Monday with them, having a meeting with the board of pharmacy there. And their law currently allows for telepharmacy, but it's pretty vague, and it doesn't define a lot of things about what it is and how it can be used. And that's where the board of pharmacy is really looking for a lot of input from different stakeholders in the state, as well as other states that are doing this. There is a pilot project that's been proposed to the board that has been under consideration, and I think what they're looking for is to get a little bit of definition around this, and then they're going to go ahead and move forward with these projects. They've all recognize that this is something that's coming to the state, and it's something that they would like to address, and they are starting those conversations now. So I would expect that within the next year or so, we would have a much clearer picture and definition of what is telepharmacy and how will it be used in the state of Indiana. Moving on to Michigan. Michigan it's a little unclear, and we're trying to work with different stakeholders right now to figure out what is the actual status. But I can tell you a couple of things. That there was a distance learning and telemedicine grant from the USDA that was awarded in 2009 to Baldwin Family Health Care. And this was to do telepharmacy in some pilot projects throughout the state. And we're not really sure. We're trying to track down the people involved with this grant to see, what the actual status, what happened, where it is, if it's still running. And I'd love to be able to give more information, but happy to provide that if you want to reach out after the call, and we can make sure and keep you updated. There's also the SB 373 was a bill that was going through the legislature in 2013, which would have given telepharmacy, it would have authorized telepharmacy and would have given the board authority to run some pilot projects. But that bill, we're not quite sure what happened to it, and we're also trying to work with stakeholders to determine, where it went and what happened. But there doesn't seem to be a clear outcome from that. So there's still some question marks in Michigan, but there has been some movement on it, and we're actively working with stakeholders. If you're interested or want more information, we're happy to provide that as well. And then Ohio is the last state here, and I left them for the last state because currently there's no laws, no rules surrounding telepharmacy. So as of today, we would not be able to do it in this state. Right now, we're already reaching out and engaging with stakeholders in the state. And one thing of note that just came out, I believe, yesterday, was that Kasich is proposing to license technicians, pharmacy technicians, in the state. And this is interesting because in telepharmacy models, typically states and governing bodies require that the technicians are certified. And there's 42,000 technicians in Ohio that right now are not certified, working at regular pharmacies. And this is going to be a huge advantage for the pharmacy industry in general in the state. So we're really looking forward to working with individuals to make sure that our pharmacy technicians are licensed. And that's good for pharmacy, and it's also good for telepharmacy. I wanted to give one last little slide here on some of the state statistics. I apologize that Michigan hasn't come back to us from our research department yet, so we don't know all of the state statistics there. But this is research that Telepharm has done in the past 6 months or so to really determine what is the need in these states. And I think a lot of people are surprised by the numbers. To be honest, I'm a little bit surprised as far as Ohio is concerned that they had fewer than 30 pharmacy deserts. But a couple of definitions here. Pharmacy deserts are areas that are 10 or more miles from the nearest retail pharmacy. That definition was ported over from the USDA's food deserts. And that was used by researchers at University of Illinois Chicago for some of their research in pharmacy deserts in urban areas, and it's also being used in rural areas as well. So there's you can see there's quite a few pharmacy deserts in each one of these states. The residence number that I have on there is just the residents that are living within incorporated city limits or communities in these rural areas. So outside of those incorporated cities, there's additional residents that are also living within what would be considered pharmacy deserts. And then the communities at risk, these are communities that currently only have one pharmacy in them. And we call those at risk because there is the possibility that if the economy or if the industry trends continue, that these cities could be at risk, and these communities could turn into pharmacy deserts where the patients are needing to drive 20 miles round trip in order to get their prescriptions. So what telepharmacy really means for these areas, for pharmacy deserts and for rural residents, is increased care. So we'll kind of circle back on some of the things we talked about earlier and how we're reversing those trends now in the telepharmacy world. So obviously, telepharmacy is going to provide access to that healthcare provider on a local level. They're going to be able to, patients in these communities are going to be able to stop by the pharmacy, see the technicians, and talk to their pharmacist whenever they need to. It prevents traveling those long distances. A lot of times, these patients are in areas that are at least 20 miles round trip. And once you add in driving time and, the actual time to get your prescriptions, it's at least an hour for these patients, many of them elderly in these rural communities. And so preventing that travel is really important. I'll also note here that what we've found is when a telepharmacy opens in a community that has a healthcare provider, so let's say a nurse practitioner or a physician's assistant, that it really benefits that practice and patients. It's a lot easier for them to attract patients, and it's a lot easier for patients to get their full primary care than right there at the facility, and they're a lot more willing to come there. And then, of course, as we saw through the studies, it reduces the dispensing errors because of the redundant checks and some of the other things that are a part of that process. So then, instead of seeing Main Street dying and some of these stores closing, what we're seeing is that pharmacies are reopening. It provides that full primary care service on a local level. It brings a business back to Main Street, which usually means renovating a building and having businesses and life in these small town communities. Of course, it means the local jobs. Telepharmacies typically employ 2 or 3 local individuals, as well as help to create jobs for pharmacists, because more prescriptions are being filled, more patients are counseling, and more attention is being given to the patients and patient care. There's increased medication adherence, and then we did a study with the Rural Economic Technical Assistance Center over in Illinois, where they estimated that in a small community, it's going to be about a $640,000 impact to the economy when they do open a telepharmacy in the community. And a little bit more on circling back on the medication adherence side, what they've found is that patients are demanding, and this is I think a blanket statement for all telemedicine and all telehealth, is that patients are starting to demand that care comes to them rather than them always having to go to care. And something that's very interesting, we saw that stat earlier, that about 1/3 of prescriptions go unfilled. What they found in this study out at Kaiser Permanente in California was that if patients were given their prescriptions immediately at their point of care, then only 5% of them did not fill their initial prescriptions. That's a huge reduction, which means a lot more people are filling their prescriptions, and they're going to be a lot more likely, if it's convenient, to then be adherent and get their refills and take their medication as prescribed. So what we're seeing is the better we can integrate these services into the healthcare system and into these rural areas, the better adherence and the better outcomes these patients are going to have. And then the last little bit here, I just wanted to give everybody a little bit of insight into where the people at the strategic level in our little niche of the industry in the telepharmacy side are really seeing this industry go, and where some of the future applications will be. What we're seeing is these little community telepharmacies are going to, a lot of times they're smaller footprint pharmacies than what you'd see. I mean, they're going to be smaller than a Walgreens or a CVS, but they're going to turn into a health hub for these rural communities. There's opportunities to connect to other healthcare providers because we're already creating this live video connection into that community, and because in the telepharmacy model, they need a physical space for the inventory and for dispensing. It makes it there's a great opportunity to utilize that to give other healthcare providers access to those community members on a local level. We're also seeing this idea of spreading technology access to pharmacists from anywhere. That means from a patient room in a hospital, when they're getting discharged, they can talk to that pharmacist. In an emergency room, like in the emergency department, the pharmacist can become available for patients or for doctors. Or ultimately on your cell phone, you're going to be able to speak with your pharmacist from the comfort of your own home, from a mobile space, which is really cool to be able to start providing access to providers in that way. Also, 24-hour pharmacist coverage. When we're able to share those resources, different networks can come together and share and pool their resources to share a pharmacist so that they can achieve more access and greater hours. And we think that's something that's going to become more and more prevalent. And then pharmacist relief. A lot of people are unfamiliar with the independent pharmacy space, but most of these pharmacists, if they're the only pharmacist in that store, they have to be there for it to operate. And so giving them the ability to take a day off if they need to, or take a vacation is something that's going to be really interesting, and we'll see how that kind of plays out in these hybrid telepharmacy models over the next few years. So that kind of wraps up my part of the presentation. I hope that I didn't drone on too long. I know it's been about a half an hour, but I'm happy to talk about any questions that you guys might have, explain things in more detail. One last caveat that I'll say: if you're interested in learning more about this stuff or staying up to date on any of the changes in regulatory environments across the U.S. or any projects that are going on, we do send out a monthly newsletter updating on those things. Happy to hop on our website and sign up for that newsletter if that's something that would interest you.
Great. Thank you so much, Greg. Go ahead and do the stop share option, and we'll take some questions. I've already got a couple of questions that have popped up in the chat. The first question was about the number of pharmacy closures, and the source that you cited said that was for independent pharmacies.
Mm-hmm.
Do you have any statistics on chain pharmacies?
We currently do not. We typically focus on the independent pharmacies. They're also the ones that are focused on the rural areas, and so that's been a big concern for the Rural Policy Research Institute is how are these independent pharmacies staying open. I can tell you that our research has shown in specific states that that chain pharmacies are closing stores as well, just not at the rate of a lot of these rural independent pharmacies. Mm-hmm. And some of the chain stores are causing rural independents to close as well, because right. They come into an area and start competing with them, so it can make it challenging.
Yeah. The next question I've got is, what are the billing codes for pharmacy? Can you talk a little bit how the billing works for Telepharm?
Yeah. So billing is exactly the same. The way that a telepharmacy works is there's still a pharmacy management system that's there on site, and that's for every pharmacy that's out there. It's a 1-to-1 ratio, so there's always going to be a pharmacy management system, and that pharmacy management system is integrated into the switch, and is able to take care of all the adjudication for us. So when the prescriptions come in, it's going to be processed just like every other prescription before they actually fill it. So really, the only difference is who owns the pharmacy. So we like to work again with the independent pharmacists in these areas. So typically, these independent pharmacists will be looking at communities to serve in their local area. So they'll have contracts with all the local employers and insurance providers that then those patients would be able to take advantage of from there.
Cool. And I think you already answered the question about research on pharmacy deserts. So how did you want to share that?
I can give that to you, Becky, if you'd like. Is that something that I can provide it on a per state level if that's easiest. I can provide it for the 4 states that you have in your network.
I think that would be great, and I can post it. I can post it on our website, and I can send it out in our next newsletter.
Okay. Yeah, we can provide the names of the communities, population, the distance to the nearest pharmacy, all those things. We're happy to do that.
Cool. That would be awesome. You mentioned your newsletter. I don't think I'm getting that, so I'm going to go to your website and sign up for your newsletter. Folks can also go to my website and sign up at the UMTRC.org for our newsletter too. That's on the front page of that site.
Yeah, very cool. Yeah, we just started it. We found there was a big interest in people knowing and kind of keeping track of what's going on in this niche. Like I said, we're more of a niche in the pharmacy side, so people were interested to know what's going on, what projects are taking place, and what are some of the changes in the regulatory environment. I can tell you, I know this is outside of the 4 states that you guys cover, but here in Iowa, they just passed this week, the House and the Senate, the legislation needed to authorize telepharmacy here in the state. So it's headed to the governor's desk. We're hoping here in the next couple of days, and then we'll be off and running here in Iowa, which is pretty exciting for us.
Very cool. Are you finding that in most states it does require regulatory changes?
Yep. I mean, typically there will be, in any kind of state regulation, there will be something in there that talks about the supervision of a pharmacist, and they usually define that as physical supervision on site. And so it takes putting in language to describe what does that supervision mean, how can it be done. They usually aren't major changes, and there's lots of states out there that are doing this and addressing this. So, I mean, every state. Typically, like I'm sure you guys run into the same thing on the telemedicine side. Every state likes to look and evaluate things on a state by state basis. So they're going to evaluate what they or how they want to implement the rules. But there's, like I said, we're happy to provide the language that's been used in other states if people are interested to see and how it's described and how it's defined.
Yep, thank you. I did get, let's see. Oh, here's an interesting question. Are any of your pharmacies on a health exchange?
That one I'm not sure about. Just to be clear, we're the technology and software provider. So the other pharmacies, we work with independent pharmacies and sometimes with health systems to provide these pharmacy services. So we help enable them. We provide a lot of services that help enable them to do this. So I'm not sure. I can definitely follow up on that question and get an answer for you guys though.
Well, and also another point of clarification: they're not technically your pharmacies. They're not Telepharm branded pharmacies staffed by Telepharm
correct
employees and pharmacists.
Right. We don't employ the pharmacists. We do have pharmacists on our staff to help guide our technology development and also help be consultants for these pharmacies so they understand the processes and all the regulation that needs to take place. But we don't provide any of the pharmacists to the clients or patient-facing pharmacists. We simply provide the technology and the software and the expertise on the regulatory and the process side of things. So yeah, you're absolutely right.
One other follow-up question I got, so on independent pharmacies, do the independent pharmacies closing account for chain store buyouts, meaning there is no active pharmacy in that location or no active independent pharmacy?
So that's what the 490 number was. Now, when I've worked with the Rural Policy Research Institute people here quite a bit, I'm happy to make an introduction if people want to ask a lot of specific questions. But I can tell you, they have looked at these areas, and the 490 those areas they've closed those pharmacies, and there hasn't been another one in that community. On the flip side, I'm sure a lot of the pharmacy owners, again, another little figure about independent pharmacies is that the average independent pharmacy owner today is 65 years old, and their options for retirement are to sell their store, but there aren't other independent pharmacies, and younger independent pharmacists that are able to purchase those stores and keep them economically viable. So typically their option for either closing or selling their store would be sell it to a larger chain. And we've seen it happen multiple times where the nearest chain is 10 to 12 miles away minimum. And they'll purchase that store, transfer the prescriptions, and then close it down. Those patients are then forced to travel. I mean, a lot of these, typically where you would see a telepharmacy is in a town below 2,500 people. So anywhere from about 2,500 to we have them. The smallest town that I'm aware of that there's one currently operating in is 560. That's here in Iowa as well. So these are very small communities, and you typically don't see the chains going into communities of that size. So the only way that you can really support that pharmacist is to have sufficient volume, and the only way you're going to get sufficient volume is through either one, having a larger population, so usually more than 2,000 or 2,500, or combining that population together using a telepharmacy model to be able to support that one pharmacist.
Greg, this is Spencer Grover at the Indiana Hospital Association. Have you been able to partner with any of your critical access or rural hospitals for part-time pharmacy coverage, for like vacations and things, or night coverage? Or is that something that isn't allowed by the licensure rules of the hospital or Joint Commission?
Right now, it wouldn't. I don't believe it would be allowed under Indiana law because it is allowed under the law, but I don't think the board would permit it. So we can work with them. And I actually was mentioning to Becky before the call that I just met with the Indiana Pharmacy Association here on Monday as well. And we're interested in getting some stakeholders together and saying, here's what we want, here's how we want to draft this language there in the state. In other states, the critical access hospitals we're looking to do exactly what you're talking about. We're working with the critical access hospitals in Illinois to do a pilot project now to combine resources throughout the critical access hospital. Say, 3 or 4 of them want to get together and have telepharmacies at these locations, and all of them help support the one pharmacist on site. So we're definitely seeing that. On the flip side, some of these critical access hospitals, they're going out to the independent pharmacies that are maybe in that community and asking them if they want to put a telepharmacy in their critical access hospital, just to be able to provide those services right on site instead of having the patient having to go to another location to receive those prescriptions. Does that answer your question, or?
Yeah, it does, and I'll send you my contact information when you're in Indianapolis again with the pharmacy board. I'd like to assist.
Yeah, absolutely. That'd be great. We'd love to have you on board.
Greg, at one point, I think we had also talked about Cardinal Health, and they provide some remote pharmacy stuff for critical access hospitals in Indiana. And had you guys talked about partnering with them? Because really you guys are focused on retail locations and they're more focused on inpatient stuff. Is that right?
Mm-hmm. Yeah, our model is all on retail and discharge. We do have good relationships with Cardinal and Pipeline for the inpatient side of things, but the inpatient skill set for a pharmacist is so vastly different than the retail or the discharge skill set. It's really hard for them to be able to make a switch and utilize that inpatient resource for outpatient. So they really do need some sort of retail or outpatient pharmacist on staff to be able to take advantage of that. But yeah, we're happy to explore any kind of models that people want to use. I think there's a lot of uses for how this can be used.
Yeah. Thank you, David, for your comments on your voluminous comments here. You want to unmute yourself and explain a little bit about your situation? Are you talking about Wisconsin or are you talking about Illinois?
Actually, thank you, Becky. Is my sound okay?
Yeah, you're good.
Okay, good. And this is a question for Greg. And, as you pointed out, Telepharm is certainly a disruptive innovation like Uber. And a friend of mine in a state pharmacy association really is uncomfortable. And she sees Telepharm as competition by out-of-state pharmacists and, job security issue. That's the way they look at it. And this is echoed by some of my pharmacist friends. And so just because this is so new, they feel a little bit uncomfortable with this innovation because they don't know how it would affect their market share, et cetera. Right. So do you have any speaking points or FAQs, something that would be helpful when we speak to pharmacist friends to reassure them that it's a win-win for patients as well as pharmacists as well as healthcare?
Yep, and I'm happy to provide that to you. I can get your information from Becky or something if you'd like, but we yeah, what we're seeing is, and we'd like to get a study put together, but what we're seeing is a lot of people are concerned that that if you start a telepharmacy, that it's going to start to draw prescriptions from where are those prescriptions coming from? Are they coming from other rural pharmacies that are out there currently? And what we're seeing is again, going back to what the studies are showing is those pharmacies will typically first of all, there's a third of prescriptions are not being filled. But if patients have convenient access, they're a lot more likely to get those filled. And then after, I can't remember the exact numbers, but after like 9 months, a lot of patients have discontinued their use of their medication and are no longer using it. So having convenient access and having that relationship with the pharmacist and the pharmacy technician that's there in town, that allows them to continue to keep those adherence rates a lot higher. I think they've said it. They've gone as high as 90% after 9 months instead of as low as 30% adherence rate after 9 months. So I think that in that sense, we're not. The pie is growing. There's going to be more prescriptions that are filled and more refills after the fact. We're also seeing that typically what we'll see is patients, when a pharmacy closes in a community, patients will, they start looking for other sources to get their prescriptions. And one of the most convenient and easiest ones for them is to go to mail order. And I don't think that mail order is a good solution for a lot of patients. That's one thing that we strive is we'd much rather have a person in the community and a pharmacist in that area be able to counsel those patients and have those patient relationships rather than going to the mail order model. I think the other thing that we're really seeing is that relationship can be really, really important for the pharmacist, and it's establishing the need for those pharmacy services. The communities now have access to these pharmacists for all those clinical activities that they didn't have before. So those immunizations, the MTMs, the CMRs, all these things that a pharmacist can do and provide in the community. Many states require, I don't know if it's across the board, but many states require at least once a month that pharmacist be on site. So that's allowing that pharmacist to come out there. It's giving access to that community. But I think overall, we're seeing that it's more jobs and more prescriptions that are being filled through these rather than seeing them go off in other ways. But yeah, I think it is innovative, and I do understand that some pharmacists look at it as a challenge or something that could be a competition to them. But like I said, I think generally what we'll see is those independent pharmacies in the local areas are the ones that are opening the telepharmacies and providing that, and it becomes more of an additional access point rather than for that independent that's already in that area, rather than a lot of chains. We don't see chains jumping into this market. They just aren't. Illinois is a great example. There's no chains right now that are jumping into this market. It's lower volume by design, and that's kind of against their business model.
Mm-hmm.
So I think we always get those questions, and happy to provide even more information for you, specific talking points and FAQs. But does that kind of answer your question?
That is very helpful, Greg. Thank you.
Yep.
Yeah, I just sent an email connecting you two. So
great. And then no, we haven't expanded to become a health hub, but we are looking at not that I know of, but we are looking at some pilot programs to see. Another kind of, I guess I'll just throw it out as another comment, is that in the research that we've done, we look and we see probably about half of the pharmacy deserts that we've identified have a local provider, either a nurse practitioner or a physician's assistant. Generally, your rule of thumb is about half. So about half of those communities don't have access to either. And what we'd like to do is work together and see, are there ways that we can provide not just the pharmacy into that community, but also the doctor, physician's assistant. So we're working on some pilot programs right now. We'd be happy to discuss that with anybody who's interested in it. Actually, like I said, because we have that physical space in these models, you know, we can provide additional services, and it's a way for people to start competing with, you know, these minute clinics and other things that are opening up at the larger chains. They can start to have a pharmacy local with a provider right there on site. We're also looking at potentially doing some other things that might be very, very interesting. Telepsychiatry, adding that into the mix. You know, any kind of specialties. So we haven't seen that yet. As of now, it's just being used as pharmacists and in specialty. There are some people out in Oregon, for example, that are doing HIV specialty counseling into remote rural areas, which is very, very cool. So we're seeing those, but we haven't actually seen a lot of these other services, at least not on the telepharmacy side. I'm not too familiar with the telemedicine side, but I'm sure Becky can fill us in on all that.
Yeah. So, all right, we do want, got about 10 minutes left. We do want to allow a little bit of time. Some folks have dialed in by telephone, so we're going to cautiously start unmuting people on the telephone, just to give you an opportunity to ask questions if you had. Any additional questions before we close for today? All right. Well, Greg, if you don't mind, can your slides for today? We will make the recording available on our YouTube page. But if I get requests specifically for slides, is it okay to send those out?
Yeah, absolutely.
Okay. And I will be speaking up in Michigan next week, so I may steal a little bit of your stuff for my presentation next week, if that's okay.
Sure thing. We're always happy. You know, for us, it's a win if people are talking about telepharmacy and how we can utilize it to provide you know, more access to pharmacists and you know, kind of expand the pharmacist role in a lot of these areas. You know, moving them into the exam room, moving them into rural communities where otherwise they would be no longer accessible. So anything we can do to help promote the pharmacist profession and access, we're more than happy to do that.
All right. Last chance for questions. All right.